All that tingles is not bends, by Dr. Frans Cronje. Divers are taught to pay attention to any abnormal signs and symptoms after diving. They are instructed to consider them as possible decompression illness, until proven otherwise. However, this attitude not only adds a certain amount of anxiety, but also may lead to an unhealthy level of attentiveness and concern about completely benign conditions that may appear during or following diving activities. Mild headaches, mild transient joint aches, skin irritations, or even mild tingling or numbness may be attributed to decompression illness quite erroneously, resulting in unnecessary medical evacuations, hospital admission, recompression treatment, and even the loss of diving fitness or a subsequent fear of diving. On the other hand, we don't want to discourage divers from seeking assistance, nor should they deny or overlook potentially serious manifestations of decompression illness. So there's a need to assist divers in better distinguishing between benign and serious conditions. First of all, the risk for decompression illness is reducible. The probability of developing decompression disorders is lowered by performing shorter, shallower, sensible, which has to do with ascents, descents, and where one spends one's time during a dive, and of course safety stops. In doing so, the dives themselves will reduce the concern that minor symptoms may be bubble-related. It does certainly not eliminate the risk, and we would want to caution divers not to fall into the "I was diving within the table so I cannot be bent" fallacy. In truth, as many as 50% of decompression illness cases in the DAN decompression illness database were taken from diving within table or computer limits. However, conservative diving does reduce the chances, certainly, of developing serious decompression illness, even if symptoms were to occur. Another way to exclude unnecessary overdiagnosis of decompression illness is to recognize certain common patterns of symptoms that are known to be due to other causes, in other words, conditions other than decompression illness, even though they may be associated with diving activities. These have been addressed in previous editions of Alert Diver and elsewhere, and include various diving-related headaches. So here we'll be focusing more on the so-called paresthesias, or partial excitement or feeling of tingling involving the skin, which can be described as burning, pins and needles, or tingling. Paresthesia, or neuropraxia, is the result of partial interruption of a sensory nerve between the skin and the part of the brain that interprets the signal caused the sensory cortex. Anesthesia is the result of complete interruption of the impulses. In most cases, paresthesias are both temporary and benign. Often it's the result of direct pressure on a peripheral cutaneous nerve or skin nerve due to a prolonged application of external application of pressure over the nerve. This is the type of numbness that may follow sitting in a fixed position over a period of time. These mild crushing or stretching injuries are called neuropraxias. This means that the structure of the nerve is preserved, but it ceases to transmit impulses for a period of time. In most cases, reversal of symptoms follows pressure relief almost immediately. However, when there is a long period of pressure, let's say for hours or days, this may take many days and sometimes weeks for the skin sensation to recover and for the tingling to subside. Such a situation may happen when wearing tight-fitting or heavy gear, or tight-fitting wetsuit, weight belt, or heavy BC and tank configuration for extended periods of time. Because any interruption of nerve conduction between the skin and the brain can potentially cause these disturbances, it is important to determine the underlying cause. Short-term neuropraxia, for instance due to a tight-fitting wetsuit, has much less significant than arterial gas embolism or decompression sickness, yet both of these may cause numbness and tingling. Fortunately, it's possible to make distinctions fairly easily with a little bit of background knowledge. Something you should know about the brain, spinal cord and nerves is that both of these segments, brain or nerves, can result in paresthesia or anesthesia. However, the distribution distinguishes the origins relatively easily. In the case of the brain, it is organized in functional areas, and the surface layer of the brain, which is also called the grey matter, is where we perform conscious thinking and where voluntary movements are initiated. This is called the motor function or motor cortex. Similarly, there are various physical sensations and signals from our five senses which reach our consciousness or sensory function at the sensory cortex. When looking at the brain, it's quite obvious that even a small injury to the cortex will result in a large area of skin numbness or tingling. For that reason, cortical paresthesia usually affects an entire arm or leg, and frequently both of them simultaneously. In many instances, it will present as either left or right side of the body being involved. This is called hemiparesia or hemianesthesia. Usually there's also a certain amount of weakness or paralysis of the affected area. Therefore, large areas of numbness, especially when these involve a whole arm or leg, and when there's associated weakness or paralysis, these are very suspicious of brain involvement and do require medical attention. The spinal cord, on the other hand, also contains areas responsible for relaying impulses for movement and sensation. There are also a large number of interconnecting filaments or axons that run between the brain and the target organs or tissues. The spinal cord is arranged like a stack of cylindrical discs in the unborn embryo, and each disc has a segment of nerve supply that maintains this relationship as the embryo grows and changes in shape. As the face and limbs form, the discs are stretched downwards and outwards. However, the sequence of dermatomes remains unchanged, even though they no longer look like discs or a stack of coins. In the fully formed fetus, there are 33 divisions in the spinal column. Each has a corresponding vertebra or bone, of which 7 are in the neck, 12 in the rib cage or thorax, 5 in the small of the back or lumbar region, and 5 in the sacrum, with 4 in the tailbone or coccyx. We won't get into the numbering of the associated nerves, as it differs a little bit from the vertebrae, but the general picture is apparent. The reason for providing this background is that injuries to the spinal cord or spinal nerves affect a particular segment or dermatome. The difference is that an injury to the spinal cord can then also affect subsequent dermatomes to some extent, because the nerve filaments that are interrupted on their journey run from head to tail or tail to head. A spinal nerve root injury only affects that specific dermatome. To put it differently, if the tube of the spinal cord is affected, there are downstream effects. If the nerve is affected once it has left the spinal cord, then only its area of distribution is affected. Therefore, paresthesias or weakness in the distribution of a dermatome indicate probable spinal cord or spinal nerve root involvement. This may be due to other causes, such as a prolapsed intervertebral disc, which is to say where the cushion or fibrous cartilage between vertebrae becomes crushed or deformed and leads to compression and interference with a particular nerve's function. If there's associated weakness, paralysis, or loss of bowel or bladder control, it is a medical emergency. Lastly, peripheral nerves. Peripheral nerves are the continuation of the filaments, the axons, in the spinal cord. They form an unbroken electrical link between the brain and the target organ or tissue they supply. The first section of these nerves, as they leave the spinal cord, are called spinal roots. In the section of the spinal cord supplying links to the arm and leg, the spinal roots mingle and merge to become a tangle of nerves called the brachial, in the case of the arm, lumbar, in the case of the back, or sacral, in the case of the pelvis or pelvic bones regions, respectively. The tangles eventually separate out into a number of blended peripheral nerves and supply the skin of the upper and lower limbs, respectively. This is one of the main reasons why there is a significant difference in the way spinal cords or spinal root damage presents itself versus nerve plexus or peripheral nerve injuries. It's also why background is important, because it allows distinctions to be made. Unlike damage to the spinal cord, which follows that stacked dermatomal pattern of sensory loss, injuries to the brachial plexus or peripheral nerves are patchy in nature. Various areas or segments or islands of skin can be affected. This may result in burning or tingling of these areas, and it differs from cortical or spinal types of injuries in that it has a more segmental distribution. If numbness is limited seemingly to random patches of skin and does not affect the entire limb, that is, it's not cortical or regional, or a circumscribed segment, in other words, spinal or dermatomal, it is probably due to a peripheral nerve or nerve plexus injury. Importantly, from a management point of view, any injury or illness that causes loss of strength or loss of function should always be considered a medical emergency. Similarly, all anesthesia, in other words, complete loss of sensation for more than a minute or two, even due to direct mechanical compression of a nerve due to position or compression by dive gear, is nevertheless in need of immediate medical attention. It is only when there is a partial sensory change or paresthesia without functional loss that divers are able to differentiate trivial from more serious injuries. There are several common diving-related injuries to nerves that will now be listed. There is no specific way in which decompression illness may produce these symptoms, and they are almost invariably related to compressive injury of a peripheral nerve. The first is lower brachial plexus compression or injury, also called heavy BC syndrome. Pressure on certain parts of the brachial plexus as it extends from the neck in the area just above where the collarbones are may result in tingling or numbness in the lower arm on the side of the pinky. Ulnar nerve or funny bone syndrome. Tight-fitting wetsuits or leaning on the elbow may compress the ulnar nerve in the region of the tunnel on the inside of the elbow and produce characteristic numbness, tingling, or burning in the palm of the hand. The difference between the brachial plexus stretching and compression of the ulnar nerve is that in the case of the ulnar nerve, only the palm of the hand is involved. When the brachial plexus is involved, the tingling may ascend from the hand as high as the elbow. Sciatic nerve or numb bum syndrome. Pressure on the sciatic nerve can be due to sitting on a hard surface. It causes classic numbness in a large area on the back of the leg, and boat rides are notorious for this. A person may feel that their leg has gone gummy, but it recovers very quickly. Failure to do so should alert the possibility of more serious underlying problems, including decompression illness or nerve root and lumbar disc lesions. Then there's the lateral femoral cutaneous or weight belt syndrome. Being overweight or having compression by a weight belt can cause an impingement of the lateral femoral cutaneous nerve, resulting in characteristic paresthesia over the upper outer thigh. To summarize, the purpose of this article is to separate the tingles out that are not the bends. However, any injury or illness causing loss of strength Weakness or loss of function, including bowel and bladder function, should always be considered a medical emergency. All anesthesia, in other words, complete loss of sensation in an area that lasts more than a minute or two, even when this is due to direct compression by a nerve, needs immediate medical attention. Paresthesia or tingling is the result of a partial interruption of sensory nerve conduction between the skin and the sensory cortex. Both paresthesia and anesthesia may be the result of damage to the brain, spinal cord, or nerves. However, large areas of numbness, especially when the whole arm or leg is affected and there is associated weakness or paralysis, are very suspicious of brain involvement and constitute a medical emergency. Paresthesias or weakness in the distribution of a dermatome indicates probable spinal cord or spinal nerve involvement. Although these may be due to other causes, such as a prolapsed intervertebral disc or the cushion and fibrous cartilage between vertebrae, these are also in need of urgent medical assessment. Lastly, however, if numbness or tingling is limited to a seemingly random patch of skin and does not affect the entire limb or a circumscribed segment, then it is probably due to a peripheral nerve or nerve plexus injury. The most common types of these are the lower brachial plexus or BC injury, the ulnar nerve or funny bone injury, the median nerve or carpal tunnel injury, the sciatic nerve or numb bum injury, and the lateral femoral cutaneous nerve or weight belt injury. Remember, when in doubt, contact Divers Alert Network for assistance and advice.